Well, I'm not too sure if you get sick of hearing that song in late spring or early summer, do you? Boys, way to bring home another championship for the city. 3 for 3, hell of a dynasty. One word of advice to Mr. Wirtz is you might want to keep Patrick Kane out of Buffalo, since not too many good things happen out there when he's traveling. Moving forward, this is our CDH version of the Region 8 CE for September 2015. Today we're going to talk about respiratory emergencies. A little bit of a low-budget film coming from CDH. We don't have all the lights and whistles. You guys are busy people. We're going to try and make this quick. We're going to talk about a few things, and I'll let you get on with your day. Please be advised that not all the content here may be Region 8 applicable. Some may be deemed just applicable to the providers for the CDH EMS system. When I was charged with the task of respiratory emergencies and delivering a video, it was kind of a bit overwhelming to me, let's put it that way. What do you talk about? Asthma, COPD, pulmonary edema, obstructed airways. Respiratory emergencies are varied. It's wide expanding. You could talk about each subject for over an hour. I know last year Dr. Darrell Wilson talked at length regarding non-invasive positive pressure ventilation. He gave a very concise and detailed update on why we use it, when to use it, and how the pathophysiology affects the respiratory system and how it improves the oxygenation and ventilation treatment of certain disease processes, particularly pulmonary edema. What can we do to enhance your skills as a medic? Nationally, intubation rates are anywhere from 50 to 80%. This journal, Pre-Hospital Emergency Care, which is written by the National Association of EMS Physicians, had an interesting article in there. A pediatric critical care transport team was studied over a several month period, and these are critical care nurses just designed to only transport and treat sick children. Their intubation success rate was 64%. I know CDH region, we hover around 60 to 70 for most of our departments. I wouldn't be too surprised if that is the average in your area. Actually, nationally, I was at a meeting in January, and that rate was roughly at 60-some% as well. So we're doing an okay job intubating people, but we would love that first pass success rate in the 70s to 80s, maybe multiple attempts at 90 plus, and we're just not achieving that. My personal opinion is, even as a physician, we're not doing as many intubations, so we're kind of losing that skill set to a degree. I have the luxury of having a video laryngoscope called the glide scope period. Hence, when I have a difficult airway, I can use that as an alternative method of obtaining and securing the endotracheal tube. However, obviously, all of you do not have such a device in the field. So some things I think you can do to improve your skill set is get out there and practice. Whether it's on a mannequin, on a sim lab, I cannot stress enough, the more you do something, the better you become at it. But that inherently makes sense. The other is get all your equipment ready. Have your blades ready, have your tube sizes ready, have suction ready, have a bougie ready if you're going to use that, and have your alternate device ready, your extraglottic airway, perhaps like your King. One thing to consider when you know you're going to intubate somebody is possibly placing a nasal cannula on them with high flow oxygen. There are some recent studies demonstrating that high flow nasal oxygen will increase the time that you have to intubate somebody. The mechanism of this is by filling up the nasal passages, turbinate sinuses, and posterior pharynx with a higher oxygen concentration. Hence, when you stop bagging them and you are attempting intubation, the oxygen passively diffuses into the lungs, hence increasing your time that you would have to intubate somebody. So you have your equipment ready, you're pre-oxygenating, you're bagging, you feel you're ready to deliver the airway, and now what do you do? If they are relaxed, you may make an attempt without any pre-medication. If they're not completely relaxed, obviously etomidate can be used in our system. After etomidate is administered and you feel they're adequately relaxed, you can make an effort to intubate the trachea. Obviously, if you go to intubate me and I do this with my neck, it's going to be a lot harder intubation than if I do this with my neck. So if this is a non-traumatic event, feel free to hyperextend their neck because it'll line the airways up much more easily and lead to easier visualization of the chords and then hence a straighter shot at the intubation. One thing we've been moving forward with in our system is bougie use, and I'm now going to show you what the bougie can do for you. If you are unable to visualize the chords fully and cannot pass the endotracheal tube directly, but you get a partial view of the chords, the bougie can help with that difficult airway. And I'm going to show you a glide scope video of us performing the bougie on a mannequin, and it will get you a sense of how to use this device. Everybody has different views about it. My personal opinion is I think you should use the bougie separately and then pass the endotracheal tube over it. I've heard of reports of placing the bougie through the endotracheal tube. I personally don't like that, and I'll tell you why. If you're using a bougie, by definition, this is a difficult airway because you're unable to pass it on the first attempt. Connecting the bougie to the endotracheal tube puts a lot of material in the mouth of that individual. My general experience is, and I've only used it 3 times in an ER setting, is those people were either very obese with short necks, or they just were very anterior, or they had large tongues. There were several reasons why I was not visualizing those chords well with a standard endotracheal tube. Hence, when I go back in, the bougie is a very thin device, and all I have to do is lift up with my blade, find the chords or a partial view of it, and then pass that bougie. And then the rest of it is a blind passing of the tube over the bougie. And we will demonstrate now how the device can be used clinically. As you can see here, the bougie goes through the chords, and you advance it as far as it will go, period. You will know you're in the right orifice because the bougie will advance to a certain length because it will be stopped by either the carina or the right mainstem bronchus. After the bougie is in an adequate position, you then place the endotracheal tube over the bougie. There may be some difficulty in passing the endotracheal tube as it gets closer to the chords, and you can rotate it counterclockwise or clockwise 90 to 180 degrees. Once you are at an adequate position at the lip, you would then remove the bougie, and as you can see here, inflate the lungs and show that you have adequate respiration with checking breath sounds and checking for a CO return. Additionally, here you'll see if the bougie goes into the esophagus, the bougie will continue to pass and there will be no end point. And as evidenced here, you will not have enough bougie to place the tube over. Hence, you're in an esophageal position and inadequate placement. There we go. So as you can see from the video, this is one adjunct we can use to possibly enhance our success rate in intubations. Nobody will ever be 100%. We can only strive for it. What I can say is anesthesiologist taught me in med school was you can bag somebody forever. So when all else fails, you can always bag any patient as long as they have a face. Or it's not completely mangled by trauma. Then you got to look at alternate surgical airways potentially, but I don't have the time to go over that at the moment. Additionally, remember there's always a supraglottic airway, whether it's a King or some other device. Become familiar with it, learn how to place it, and remember you can always use that in case of a failed attempt at intubation. In summary, I wish you well out there. Do the best you can. That's all we can ask of you. Follow your SOPs. If you ever have any questions, ask one of the docs or medical directors. That's what we're here for, is to help provide you with the best education we can. Enjoy the brief remainder of your summer, or what's left of it, and go Hawks.